Good evening, everyone. Thank you for joining us. My name is Donna, and I'm with GENESIS Fertility. Conducting the seminar tonight is Dr. Alex Kotlyar. Dr. Kotlyar will be speaking about endometriosis, what causes it, and how we can help you. Dr. Kotlyar is a fellowship-trained specialist in reproductive endocrinology and infertility. I'm going to ask everyone to please hold all questions until the end of the presentation. And without further delay, I'll turn the controls over to Dr. Kotlyar.
Good evening, everybody. So I will be discussing endometriosis, and we'll be discussing what it involves and is it really just a pelvic disease. So the first question is, what exactly is endometriosis? Put plainly, it's the presence of endometrial tissue that's outside of the uterus. So symptoms that would make one suspect endometriosis are unusually painful periods that lead to an inability to do even everyday tasks. For example, pain during intercourse, frequent non-menstrual pelvic pain, and infertility for which we can't find an obvious cause. As far as how often we see it, about 10% of reproductive age women experience endometriosis of some form. Unfortunately, because of both a lack of patient information, provider information, and conceptions of what pelvic pain is for a woman, most women spend anywhere from 4 to 11 years before they get a definitive diagnosis of endometriosis. Endometriosis is seen in about 50 to 60% of women with chronic pelvic pain and in up to 50% of women with infertility. The next question is, why does this happen? So the most prevalent theory is that women experience not just menstruation through their cervix, but it can go the opposite way. We call it retrograde menstruation. And prior studies have shown that it occurs in 90% of women. There are also additional theories behind the cause of endometriosis involving bone marrow stem cells from other non-uterine tissues. It's even thought that the inner tissue of the belly, what we call the peritoneum, can transform into endometriotic tissue. And this tissue can spread either via blood vessels or via lymph nodes based upon various studies. This next slide comes from a paper that was recently published by myself and a few colleagues back at Yale. So it shows both cells coming from retrograde menstruation, bone marrow-derived stem cells, and from other tissues transforming into endometriosis lesions. So is there a genetic link? Based on studies in many families with endometriosis, there is a linkage. If a mother or a sister has had an endometriosis, it's more likely the patient herself will have it. But after looking at many genes, no exact genetic culprit has been found. Even a combination of genes hasn't been implicated yet. So once a patient's history is suspicious for endometriosis, when they endorse having chronic pelvic pain with or without painful periods, in addition to other symptoms like painful intercourse, painful urination, or painful bowel movements, we need to proceed with a more in-depth diagnosis. That first involves an exam, seeing if there are any tender nodules or if there are any ovarian masses, which we call endometriomas. Then we should proceed on with imaging. A transvaginal ultrasound is one of the best initial tests, since it can show us ovarian endometriosis and any large lesions of endometriosis. MRI is even better for looking at other types of endometriosis. You may hear a term called deep infiltrating. MRI is great at that. Some providers will measure a tumor marker called CA125. Many benign conditions can elevate this, including endometriosis, but also fibroids can elevate it. This can even be elevated during menstruation. So a point I wish to emphasize to all the listeners is if A CA-125 is measured, and if it's elevated, it's not necessarily a cause for concern, since while it's not diagnostic, it further bolsters a presumptive diagnosis of endometriosis. The gold standard for diagnosis is to put a camera inside a woman's belly and see if there are any lesions concerning endometriosis. So hence that's diagnostic laparoscopy. So once the clinical suspicion has come up, or surgery has been done and endometriosis has been noted, and just another caveat here, a woman does not necessarily have to go through surgery to have a presumptive diagnosis of endometriosis, meaning she can still be treated for presumptive endometriosis without going through the surgery. If, for both the provider and the patient's benefit, they want a definitive diagnosis, then they certainly should do surgery. But if the symptoms are suggestive, they can just proceed with treatment. First-line treatment are non-steroidal anti-inflammatory drugs like ibuprofen or naproxen. The next level are birth control pills, which usually have some form of estrogen in them, usually estradiol, and another component called a progestin, a synthetic version of progesterone, what a woman's own body makes. For birth control, it's best used continuously, so it induces what we call a pseudo-pregnancy or fake pregnancy state. About 2/3 of women will experience relief, improvement of their pain while on birth control pills. If those birth control pills alone aren't effective, patients could try just the synthetic progesterone version. And I've listed a few options. I've also listed down below something called the levonorgestrel IUD or intrauterine device. It's especially effective when women have isolated painful periods, and in at least 2/3 of women, they also experience some form of pain relief. For patients that either can't tolerate those treatments or don't experience any pain relief with progestins or birth control pills or the nonsteroidals, they can get what are called gonadotropin-releasing hormone-like agents or analogs. A very common one in the United States is called Lupron or Luprolide. What they do is they induce a low estrogen state, endometriosis being a hormone responsive condition, especially an estrogen responsive condition. If you can take away that estrogen, you can basically starve the endometriosis, and it helps it regress. The side effects are exactly those that women experience with low estrogen: hot flashes, vaginal dryness, decreased libido, and most importantly, decreased bone mineral density. It's less of an issue in the first 6 months of treatment, more of an issue after 6 months. So after 6 months, if women are still on these agents, they should get back some small amount of weak estrogen, and that's called add-back therapy. There's also another medication called danazol, which is a derivative of the male hormone testosterone. That leads to a high testosterone, low estrogen state. It's considered more of a third-line agent because of its side effects, which include weight gain, effects of having high male hormones such as acne, oily skin, thickened hair growth, and higher cholesterol. Women will also have thinner vaginal skin, hot flushes, and they may be more irritable. So for all of those reasons, I and many providers across the country tend to use this as a third-line drug. Surgery can also be a very effective therapy. The main disadvantage with all of the prior therapies mentioned before is that they prevent a woman from properly cycling each month, releasing an egg each month, and it'll severely decrease the chance for getting pregnant. So if a woman's planning pregnancy, those medical treatments are not ideal. Surgery can be helpful for a woman who wants to control her endometriosis and wants to achieve pregnancy. So for women with all forms of endometriosis, surgery can improve their symptoms. However, recurrence is very likely. Approximately 50% of women in 5 years after their surgery will experience some recurrence of their symptoms. So in the long term, they will need to be placed on this hormonal therapy. Now, going back to the title of this slide, endometriosis has been shown to have more wide-ranging effects than just in a woman's pelvis or in a woman's belly. At least in animal studies, they've also found effects and endometriotic cells in the liver, in the brain, in the spleen, in other tissues, including even fat tissue. In addition, women with endometriosis have many pro-inflammatory factors that are circulating throughout their body. Hence, we're realizing more and more that endometriosis is not just an isolated gynecologic and pelvic disease. It's systemic and it's chronic and needs prompt and well-managed treatment. It is not just a pelvic disease. So knowing that, what does the future hold? One, better non-invasive diagnostic tools using various blood markers. The goal also using those blood markers is to better tailor hormonal therapy to each patient. We call molecular typing, which is exactly what's done, for example, for breast cancer testing. Also, there are multiple agents, such as immune modulating agents, that can help decrease the inflammation of endometriosis, and that could also allow a woman to get pregnant while they're getting treatment for endometriosis too. So those are in the pipeline.
Does it run in families or is it hereditary? And I think you did address that.
Yes.
Yes.
So if a mother or a sister has it, then there's a higher chance that the patient herself could have it too.
I was diagnosed with adenomyosis. What is the difference?
So adenomyosis, it's related to endometriosis. One could think of them as basically the same disease. So adenomyosis is when you have that endometrial, so the inside of the uterus, we call it endometrium. When you have that endometrial tissue, not in the belly like in endometriosis, but inside the muscle of the uterus itself. And one great comparison that that one of my mentors taught me was because that lining, it can thicken up and it can bleed each month. Imagine it like having a bruise in your muscle that worsens once a month. So that's where that pain can happen once a month with adenomyosis. So they're both related. It's once again that lining not being in the right place.
Does the pain a woman experience decrease after a woman has a pregnancy?
So it could. It's really variable. So what I tell all my patients that pregnancy could lead to some resolution or even complete resolution of the endometriosis, but no guarantee could be made. And I tell them that once they've had their pregnancy and say, for example, they've completed breastfeeding, because breastfeeding also leads to a low estrogen environment, then they could still experience a relapse of their endometriosis. I would love it if there was a reliable way to control endometriosis via diet. Unfortunately, there isn't a lot of good data showing that any one diet or any one group of foods is really effective at decreasing inflammation. And I would say it's not just inflammation, but also the passage and survival of these endometriosis cells. This actually brings up another point. In terms of having just a healthy diet, a well-balanced diet, and minimizing stress, that in and of itself can help patients deal with the pain of endometriosis. But as far as any particular diet in and of itself, unfortunately, I don't have any data that supports it.
Can endometriosis be completely symptomless? And if so, does that mean it's a less severe case?
So that's a superb question. It can absolutely be symptomless, but what we've realized is that the symptoms don't go along with the stage, with the severity of the endometriosis. I've seen women who have terrible daily pain and who can bear and whose periods are so painful they can't even function during that time. And we put a camera inside their belly and they just have a few tiny dots near their uterus. Whereas I have patients that come in, no issues whatsoever, and they have a very foreboding looking scarred over pelvis where the anatomy is completely distorted. So there's no good way to predict just based upon symptoms.
Can endometriosis affect the tubes? And can surgery help with this?
So endometriosis absolutely can affect the tubes. And that's one of the reasons why 30 to 50% of women with endometriosis have some degree of infertility. The degree of scarring or scar tissue around the tubes, that influences how easily surgery can influence it. If, say, for example, there's all scar tissue around the ends of the tubes, well, we can do something called a fimbrioplasty, where we can undo that scar tissue and open up the ends of the tubes and try to get them working again. If, for example, there's a scar tissue involving bowel or other important structures like the ureters, we have to strike a balance between the amount of dissection we need to do and the possible risks of that dissection. So if there's that much scar tissue encasing the tube and other important structures, for the safety of the patient, we forego the tube at that point.
If I have endometriosis, should I do IUI or IVF?
You can do either one. It depends upon age. It depends upon clinical history, the severity of the endometriosis, and most importantly, how the tubes look. If there's, in general, the older a woman, especially after 35, or especially if there's a lot of concern for scar tissue and a lot of endometriosis, then it would be more worthwhile to do IVF potentially. But before that decision, we would do a test to check the tubes called a hysterosalpingogram, an HSG.
Just for the people who are listening, what exactly is that, the hysterosalpingogram?
Yes, so a hysterosalpingogram is a specialized test where a woman has some X-ray, some dye that we can see on X-ray, put into her uterus, and it's very gently pushed through. And then using X-rays, we can see it go through her uterus, and her tubes. And then we see it spill around, and it tells us if the tubes are open.
Can endometriosis affect my frozen embryo transfer?
So indeed it can. In fact, it's recommended in women with confirmed endometriosis and adenomyosis for that fact to undergo treatment with an agent called Lupron, which is that gonadotropin-releasing hormone agent, agent, for a couple of months beforehand. It's thought that endometriosis it leads to an inflammatory environment. So yes, so for those women who want a frozen embryo transfer and that have endometriosis, our goal is to give that agent, that Lupron, to just quiet down the endometriosis for a couple of months and decrease the inflammation and make the uterus just a happier place for that embryo to grow and thrive and one day go to college.
How do you advise women should advocate for themselves if they think they have endometriosis so their doctor can look into this diagnosis?
So knowledge, first and foremost. If a woman has very painful periods, especially debilitating periods, or any combination of those symptoms that we discussed, then she needs to emphasize it to her doctor, and even if the doctor isn't willing to do surgery, they should still encourage that doctor to at least try some form of medical management, medical treatment. And if the doctor's so willing, especially if they're a well-trained obstetrician gynecologist or infertility specialist, then they should be very comfortable taking the patient to the OR and putting a camera inside their belly and confirming it for the patient. So knowledge first and foremost.
So do you think a woman should make the appointment first with her regular GYN? Go that route first?
Yes. So as experts in women's health, an OBGYN should be the first go-to. And if, just as we mentioned, women take at least a couple of years to get an accurate diagnosis. I fully encourage women that if they don't get a reassuring or a conclusive assessment from their doctor, then they absolutely should go for a second opinion or see reproductive experts like us here at Genesis.
Does endometriosis cause diminished ovarian reserve?
So that's a good chicken and egg discussion. There's a lot of good theoretical evidence that because of the inflammation that can lead to damage of the eggs and eventually lower egg quality. As far as any large population studies, to be honest, I'm not really aware of it. Another confounding factor is many women with endometriosis eventually do undergo surgery, and we know surgery, especially in the ovaries, does tend to diminish some amount of the eggs a woman has.
If anybody has any other questions, you could always email them in to info@genesisfertility.com, and we will get you an answer. Thank you, Dr. Kotlyar, for joining us tonight and giving this presentation.
My pleasure, Donna. Thank you so much, and thank you everyone for joining tonight.